Hi, my name is Dr. Kelly Gallagher. I'm in the Department of Otolaryngology, Head and Neck Surgery at Baylor College of Medicine, and I'll be talking about nosebleeds, or what's called epistaxis, more formally. So in general, the vast majority of nosebleeds actually require very little treatment or intervention. Only about 10% actually require treatment or intervention, and it's often in either an emergency room or inpatient setting. It's important to know the nasal anatomy because the cause of epistaxis is really helpful in directing management of nosebleeds. So we'll first talk about some nasal anatomy, and of course the vast majority of nosebleeds are related to the nasal septum, and in the next diagram I'll show illustrations of the turbinates, nasopharynx, blood supply of the nose. So on this illustration, you can see a profile or sagittal view showing the septum actually cut away, but you can see the inferior turbinate, the middle turbinate, the superior turbinate. You can see the nasopharynx here, and you can see the sphenoid sinus there. In talking about the blood supply, which really is key to understanding the underlying cause of nosebleeds, we can visualize in this illustration both the anterior blood supply and the posterior blood supply. So when talking about the vast majority of nosebleeds, we're talking about anterior nosebleeds, which are located at what's called caesaal plexus or area, and it's the confluence of blood vessels from the ethmoidal arteries, in particular anterior ethmoid arteries, as well as septal branches of the greater palatine artery. Posterior nosebleeds, in contrast, are related to the branch of the sphenopalatine artery, which is a distal branch of the internal maxillary artery in the external carotid system. The ethmoidal arteries, importantly to note, are branches off of the ophthalmic artery and the internal carotid system. The cause of epistaxis sometimes may not be known, but is often related to low humidification, not enough moisture, and overall dehydration. This is often why we realize that nosebleeds are more common in the wintertime. Digital manipulation or trauma can be a cause, particularly in the pediatric population. Any kind of inflammation related to an upper respiratory infection or acute rhinitis can be tied to epistaxis, and overall inflammation increases the local blood supply. Trauma in the form of lacerations or craniofacial fractures can lead to significant epistaxis. Foreign bodies, if they're in the nose for a period of time, can lead to erosion and epistaxis. Septal perforation or deviation can alter the airflow in the nose and lead to turbulence and focal drying of certain areas of the nasal mucosa. Different patient factors can also be tied to epistaxis. In particular, hypertension, increased blood pressure levels can open up the superficial thin blood vessels of the anterior septum. Patients that are anticoagulated, in particular, are inpatients that are either on a heparin drip or Plavix or Lovenox, or outpatients on warfarin are at increased risk of having any form of nosebleed. In particular, patients with liver failure can have decreased clotting factors overall and may have some associated thrombocytopenia or even a poor functioning of existing platelets. Blood dyscrasias, including leukemia, similarly can lead to poor functioning platelets or decreased number of platelets. Any kind of nasal or sinus tumors can also cause epistaxis. There are certain hereditary diseases, also known as hereditary hemorrhagic telangiectasia, or HHT. It's also known as Weber-Raynaud-Osler syndrome. Is known to have patients with recurrent large volume bleeds related to arteriovenous malformations within the nasal cavity. A large percentage of patients, up to 25%, do not have an underlying cause of their epistaxis. Importantly, a patient's history is usually diagnostic in helping us determine whether a nosebleed is anterior or posterior, which really is the key factor because it determines how these patients with epistaxis are treated. So patients that have an anterior nosebleed, in this picture is an example. This is the right nasal cavity with a right superficial anterior blood vessels, and you can see this dominant vessel bleeding here. For reference, this is the right inferior turbinate and the right middle turbinate. Again, anterior nosebleeds are the vast majority of nosebleeds and are often easy to localize. Posterior nosebleeds, in contrast, can be more difficult to localize because of their intermittent nature. Oftentimes, they're large volumes. Patients may often describe feeling blood go down their throat before coming out of their nose. Patients with posterior nosebleeds traditionally have more significant and numerous comorbidities, and they're often more common in older men with hypertension. And this picture depicts a posterior nosebleed. This is also a right nasal cavity with the septum here. This is the choana with the nasopharynx. This is the inferior turbinate, and there's bleeding coming from inferior to the middle turbinate. As you can see, it's less easy to see the vessel bleeding directly because of the structures anterior to the vessel itself. Again, the most important or helpful part of diagnosing epistaxis is really localizing the bleeding site. So certain instruments are helpful in localizing the source of the bleed. In particular, a nasal speculum, and nasal suction cannula is also very important. You'd want to remove any clot overlying the source of possible bleeding, not only to help for identification, but also to help them symptomatically to improve their nasal obstruction related to significant amount of clot. Good headlight is necessary when you're doing anterior rhinoscopy. As otolaryngologists, we often utilize nasal endoscopy to evaluate the posterior surfaces, particularly when we're suspicious about a posterior nosebleed. And of course, anytime you may be in contact with a patient's blood or body fluids, it's important to utilize universal precautions. So when we're dealing with an anterior nosebleed, it's important to help from a patient comfort standpoint by topicalizing the nasal septum and the nasal cavity, and that's often done with lidocaine spray or jelly. One of the most common interventions we do on an outpatient basis is silver nitrate cauterization. And this very simply cauterizes or obliterates the vessel and also creates a scar where the mucosa overlies the vessel to prevent future nosebleeds. There must be some caution when you do cauterization, because if you were to cauterize opposite sides of the nasal septum, then you could place the patient at risk for perforation, or if you cauterize two opposing mucosal surfaces, such as at the nasal vestibule, then you could run a risk of scar tissue formation. There are multiple tools available when considering nasal packing to treat anterior epistaxis, and in general, this is done in situations where conservative measures have already failed. The most common conservative measures we recommend either to patients on an outpatient basis or even when we're getting an initial consultation is to use topical decongestant spray such as Afrin or neosynephrine, which acts as a vasoconstrictor to help decrease the amount of blood flow and thus decrease epistaxis. And of course, holding nasal pressure at the junction of the cartilaginous and bony septum can also be helpful. And we usually tell patients or primary teams to hold pressure for at least 10 minutes with no peaking, because again, that treats the vast majority of minor nosebleeds. And when those situations fail, then we have these options at our disposal, which include a Maricel or rapid rhino packing, which require later removal after 2 to 5 days. Surgicel, gel foam, and other thrombostatic agents can be helpful, and they're especially useful in patients who have factors such as thrombocytopenia or are fully anticoagulated, and where we don't anticipate their status, their anticoagulated status, to improve after 5 days. And using these resorbable materials is helpful because you don't cause the trauma in removing them that you may with the more other formal packing that requires removal. Lastly, the 1/4-inch gauze is also an option. It was the original traditional form of packing, and I'll give you some illustrations of the various techniques here. And this is a diagram of silver nitrate cauterization. You can see this plexus of vessels at the anterior septum. This person's using suction to get better visualization, and then a silver nitrate stick for chemical cauterization. These examples of removable packing include mirror cell above, which shows that it's more or less similar to a tampon in the sense that it expands once it's placed inside the nasal cavity. The alternative is a rapid rhino, which is, I feel, a little bit softer, is a little bit easier to place. And then one advantage to rapid rhino is that you can remove the air prior to removing the whole pack, which puts them at less risk for abrasion, whereas a mirror cell doesn't ever compress or decrease in size after it's placed, so runs a higher risk of abrasion when the pack is removed. Again, this is the example of gauze packing where you would use forceps and layer antibiotic petroleum soaked gauze into the nasal cavity. This can be helpful in patients where there is just diffuse mucosal oozing, or in patients that have had instrumentation like a Dopphoff tube or nasogastric tube, such as in our inpatients or ICU patients. In those patients that have severe epistaxis, you have to do a thorough evaluation looking at their CBC and their coagulation profile. And patients that have thrombocytopenia, again, you want to use caution and gently pack because removing any packing could re-traumatize mucosa, and with either low platelets or dysfunctional platelets, then it would be difficult once again to form a clot, and you can run into a cycle of repeated bleeding after packing. In elderly patients, you really have to be careful to monitor regularly the hematocrit and oxygen. And in some isolated cases where the more conservative packing is not successful, or they have really severe volumes of bleeds, or patients have bled through the packing that's in place, then we have more invasive procedures as options, including endoscopic cauterization in the operating room, vessel ligation in the operating room, either of the anterior ethmoid through a Lynch incision, or of a formal ligation of the internal maxillary through a Caldwell-Luck kind of procedure. Finally, we also have colleagues in interventional radiologies that can assist in performing angiography and embolization with posterior nosebleeds. It's important to note that embolization is never an option for anterior nosebleeds because the proximal source of the vessel is the internal carotid, and the risk of embolization to the ophthalmic artery is too great to even attempt embolization in an anterior nosebleed situation. So this is an example or illustration of posterior formal packing in which a Foley catheter is placed into the choana and inflated above the soft palate and puts pressure on the branches of the sphenopalatine artery that cross the sphenoid sinus, which is here. And then on top of that, there's gauze, petroleum or antibiotics ointment, soaked gauze to more diffusely place pressure against the sources of bleeding, which may come from the anterior or posterior ethmoid arteries. Patients that have formal packing in place are often monitored in an ICU setting because of a risk of a cardiopulmonary reflex because of the pressure. Finally, again, treatment for posterior epistaxis could involve a trip to the operating room. There's a procedure called a TESPAL, or a transnasal endoscopic sphenopalatine artery ligation, which involves removing the tissue anterior to the artery. There's a bony prominence called the cristoethmoidalis, just posterior to the natural os of the maxillary sinus here. This is an example on the left side. and you can see the branches coming out of the sphenopalatine foramen. Usually there's about 3 branches, and it's recommended to ligate or clip at least 2 or 3 of the branches to make sure that you have hemostasis after the procedure. Once more, our IR colleagues can be helpful if these other more conservative measures fail, or in particular in patients that have craniofacial fractures where it may be difficult to access the vessels directly, then embolization can be a very helpful and useful adjunct. And that's the end of the presentation. Please feel free to email me if you have any questions. Thank you.